Hi, good afternoon, everyone. We're going to get started in just a few seconds as everyone moves from waiting room into the webinar. Thank you for joining us. Good afternoon, everyone. Thank you so much for joining our webinar today on lessons learned, transitions of care for people experiencing homelessness from the hospital setting. My name is Ashley Brand, and I'm the System Director for Community Health Integration and Housing at CommonSpirit Health. And we are honored and excited to partner with the National Healthcare for the Homeless Council and USC Street Medicine to support this learning opportunity. Most importantly, we're grateful for all your attendance and commitment to this work as leaders and collaborators. As we know, 90 minutes is a long time to take out of your schedule, and we are grateful for you to participate today. I will now pass it to Katie for a land and labor acknowledgement.
Thank you so much, Ashley. I'd like to take a moment. Our conversation today includes all of us who are located across many communities. Most of our communities reside on unceded ancestral land or acquired land by unhonored treaties. We acknowledge the people of these lands, past and present, and honor with gratitude the land itself and its people. We also honor the brilliance and humanity of all immigrant labor, including voluntary, involuntary, trafficked, forced, and undocumented peoples whose labor remains hidden in the shadows but still contributes to the well-being of our collective community. By recognizing the land that was taken from First Americans and the forced labor that was provided by enslaved Africans and Black and Brown people, we strive to take steps towards creating a more equitable and just world for us all. And we will drop some resources into the chat so you all can learn about the land on which you currently reside.
Thank you, Katie, for that. In addition to our land and labor acknowledgement, CommonSpirit has a tradition of starting our meetings with reflections to help ground ourselves. Today's reflection comes from Benjamin Bletch. May you replace ease with effort. May you find joy in always scaling new mountains. May you never rest from pursuit of knowledge. May you desire to always be a little better than yesterday and a little bit less than tomorrow. Thank you for allowing us to provide a reflection. For those who may not be familiar with CommonSpirit Health, we were created by the alignment of Catholic Health Initiatives and Dignity Health as a single ministry in 2019. This merger created the largest nonprofit healthcare system in the United States. CommonSpirit Health currently owns and operates health facilities in 24 states and is comprised of approximately 2,300 care sites, including 137 hospitals. Our commitment to serving the underserved is ingrained in the culture of the organization. CommonSpirit Health is committed to building healthier communities, advocating for those who are poor and vulnerable, and innovating how and where healing can happen, both inside our hospitals and out in the community. Our value of collaboration is foundational within our efforts to addressing our patients and community members experiencing homelessness. Our vision states a healthier future for all, inspired by faith, driven by innovation, and powered by humanity. For our agenda today, we have a packed-filled 90 minutes, and we will leave time at the end for Q&A. This is being recorded, the slides will be sent out, and we will also go over the CEUs. So just want to make sure we cover that, and we'll make sure we put that in the Q&A as well. We'll open today's agenda with a Mentimeter to really look at who's in the room, followed by our colleagues to introduce street medicine, followed by strategies for supporting unhoused individuals during hospitalizations. Our council members will go over the hospital discharge toolkit, and then again, we'll leave some time for Q&As, along with some housekeeping around our CEUs. So stay tuned for more information there. For our speakers today, we are honored to have Brett Feldman and Corinne Feldman, directors of USC Street Medicine, and who are bringing firsthand experience of providing medical care to our unhoused community members. We also have our stellar colleagues and friends from the National Healthcare for the Homeless Council, Caitlin Sinovec, Assistant Director of Medical Respite, and Katie League, Behavioral Health Manager, who have made this webinar possible. Katie, I will now hand it over to you.
Thank you, Ashley. You will all see this slide again, but we wanted to, as Ashley mentioned, we are very fortunate to have, as part of this training today, the opportunity to provide you all with continuing education units for prescribing providers, nurses, social workers, physical therapists, as well as occupational therapists. So these slides will be available. This information will be available on our landing page. We will have lots of times for you to collect this information and make sure that you get your CEUs. But we wanted to put this right from the front. It is so important. We know, and we're very grateful for you spending your time with us today. And then a note, you probably have all realized, because there are over 300 of you in this space, we have turned off the chat feature, but we do ask that you use the Q&A feature for submitting your questions to us. And we will be able to field those all during the presentations. If there's something small, we will direct them, we'll answer them in that Q&A. And we will also have a live Q&A session near the end of our webinar today, and we will bring those questions forward in that space. For those of you who have attended something at the council before webinar, you may be familiar with this. We use this platform. It's a great way to hear more about who is in the space with us. It's called Mentimeter. So you can access this a few different ways. You can use the QR code if you have a phone or a tablet available. You can go to menti.com and enter that 8-digit code number. And when you get there, you will be able to see in the lower right-hand corner the little thumbs up. I'm seeing some thumbs up coming. We'll give everybody a minute to do this. And if we can, we will drop the direct link in the chat as well. But there's two concrete ways to get into this space. Perfect. Thank you to Caitlin. That direct link is now available. So we are going to move forward. The first, we'd like to see who is in this space with us. If you can, this is one where you just drop a pin as to where you are. I recognize that this is very Western civilization centric of me, that the places that I only put the map of the US. Please feel free to correct me and put a dot somewhere indicating if you are outside of the United States. Really great representation. So exciting. Look at that from all over. So wonderful. Not that I'm not interested. I'd love to hear who you're all come from. We want to move along. So I know everyone here in this room likely wears many hats. So take a moment of which job role you most identify with. Maybe that's for today. Maybe that's in your title. Maybe that has to do with the acquisition of licensure that you feel most proud of. I know many times you are doing lots of things, and so appreciate that people likely might fall in many different components of this. So really, really nice distribution. It looks like we have a lot of community-based homeless service providers. Welcome. Lots of community-based healthcare, hospital staff. We broke you down into groups, so you are still a huge portion of this, I realize, in lots of subset, but really excited to have you all with us. Thank you for being here. Two quick scaling questions on a scale of 1 to 5. How smooth is your hospital discharge process for people experiencing homelessness? So not smooth at all is a 1, and very smooth is a 5. Looks like we are hovering in that mid-2 range. That means this conversation is so important, and we are all in the right place to have this conversation and learn from one another. I'm so excited for you to hear from Corinne and Brett today, and Caitlin and I are really excited to share with you our toolkit. And one last scale, how would you rate the relationship between hospitals and community-based homeless service providers in your community? So this could be answered in a few different ways, on a systems level, on an individual level. I am sure you all are the ones who are serving as that glue if the relationship is not as strong as you would like it to be. Our hope today is that we're going to be able to provide some concrete things that will make it so that you can feel more equipped to strengthen this relationship. So without further ado, I am going to hand it over to my amazing colleagues and friends, Corinne and Brett Feldman from USC Street Medicine. Corinne and Brett?
All right, thank you very much. Thank you for inviting Corinne and I to speak. And I just loved seeing the poll and see who's there because it occurred to me that even though this was originally thought, we thought we were going to be talking mostly to hospitals, there's a lot of people from the community who are probably wondering what's happening in the hospitals before they come out onto the street, and then people in the hospitals that are like, how can we work better with the people on the street? And and then how did Corinne and Brett, those street medicine people, end up talking about hospital transitions? And so we'll do our best to try and at least start the conversation about all of these things. But for those of you who aren't familiar with street medicine in general just recognizes that people experiencing unsheltered homelessness who we serve, that we have to address all the various forms of poverty that afflict them if we want to come close to being able to care for them the way they deserve to be cared for. So of course, there's the material poverty for want of a home or want of food. And we know in LA where we practice that almost 30% are eating 4 or less meals a week. There's a poverty of health, physical comorbidities, substance use disorders, and psychiatric disorders that if not treated now while they're on the street, will prevent them from ever walking over that threshold into housing or being able to keep that housing. But as horrible as those things are, the worst poverty that we see is the spiritual poverty of feeling unwanted or unloved. A poverty only deepened when a neighbor calls to have another neighbor's encampment moved, and they find themselves being pushed all around the town that they feel is their home, but no place to put their physical body. And so in response and recognition of their sacred humanity, we go to the people, first to deliver an understanding love, and then the same quality of care on the street that they'd expect in a brick and mortar clinic. But I start by first actually asking the question, which is the best place to deliver that understanding love? The best place to deliver it is wherever that person is. And so whether we're meeting them on the street or meeting them in the hospital, then becomes the best place. Corinne and I both first started our careers in the hospital setting, working at Lehigh Valley Hospital. She worked in trauma. I was a hospitalist, and started noticing that as much as we cared for and loved the people that were experiencing homelessness that came into the hospital, once they hit the chaos of the streets, there was very little that we felt that we could do. And as hard as we tried, as hard as our colleagues tried, there was this futility merry-go-round that really weighed on us. And at the same time, simultaneously, 2007, we started our first shelter-based clinic at the Allentown Rescue Mission and noticed the same thing, the same frustrations that no matter what we seemed to do, we were tied to the hospital, we were tied to the shelter, and that once they left those areas, we were essentially blinded to what was happening with them. And that began to weigh on us. And then there's that one sentinel patient that just changes the way you view things forever. And for us, it was a gentleman who was in his 40s but had an intellectual disability. And he was kicked out of the mission for having a pornographic magazine, which was not allowed into the winter in Pennsylvania. And we were so afraid he was going to starve to death or freeze to death. And so we went looking for him. And I found him not far from the mission under this bridge. And I remember going down under this bridge, not being on the street before. And he was sitting there. He's like, "Hey, Dr. Brad, so excited to see me." I couldn't believe he looked better than he did in the shelter. He was well dressed, well fed, with this whole community that we didn't know. And so not knowing that what we were doing was called street medicine, we started seeing him and his friends under the bridge. And then there was an incident where one of the friends ended up with an acute abdomen, and knew that I had worked at the hospital and walked 6 miles to come see me. And this was before the ACA, before Obamacare, and we didn't take people who were uninsured. And I remember him, so I had to come down and tell him that even though I saw him under the bridge and even though he had walked 6 miles to see me, that I wouldn't be the one to care for him. And I remember the look in his eye was mad and sad and confused. And I just felt so ashamed of myself and so ashamed of my profession. I just wanted to rip off my press white coat and never put it on again. And I think in a lot of ways, psychologically, I did that day. I know Corinne shared those same sentiments. And I went back under the bridge to ask forgiveness, and by their grace, they gave it to me. And from then on, the hospital has always been both a starting point for not just our programs, but where we wanted to meet folks. I then learned that what we were doing was called street medicine and that we were connected to this much larger global network with the Street Medicine Institute. These are some of the areas where the Institute is. I'm on the board of the Street Medicine Institute, and Corinne does a lot of work with them too. My role is to provide technical assistance to our members. And before we get further, it's important that we define street medicine so we know what we're talking about. So street medicine, the historic and global definition, and also the trademark of the term belongs to the Institute, which includes health and social services developed to people who are unsheltered in their lived environment. And now, for the first time, we have a federal codification of this work, also making it reimbursable. Before, we couldn't get reimbursed for this work. We haven't been reimbursed since 2007 because you could bill for what you were doing, but not where you did it. And so we needed a where. And CMS came out with Place of Service 27, recognizing the street, a location on the street or found environment not described by any other place of service code, such as 15, which is mobile units, where people provide services to unsheltered homeless individuals. So now there's a alignment between the federal definition and the global and historic definition, also allowing for reimbursement. But this is part of a continuum of medical outreach. Of course, we do street medicine, but we're not saying that one end of the continuum, street medicine, is good and the other end, the mobile units, are bad. It's all part of the same continuum, but it is important to understand the difference. There's a philosophical difference and a practical difference. That philosophically, we want to be able to suspend our reality and meet the people in their reality where they feel most comfortable. Even if we drive in proximity to them and we park, they come to us and come into our space where we feel most comfortable. We flip that power dynamic back in our favor where we don't want it. Practically speaking, it looks like this. So this is Lincoln Heights, which is an area in LA that we cover. The Red Cross on the bottom is LA General Hospital. That's the big county hospital. To the upper right is where you see the bus is Lincoln Park, where the mobile vans can park. And I'm glad that they park there. They can bring shower services and clothing services, and there's lots of people experiencing homelessness there. The problem that we're trying to solve for with street medicine is that the largest encampment in the area is where the heart is, which is over 2 miles from Lincoln Park and about 1.5 miles from the hospital. So geographically, the hospital is actually closer than where the mobile unit parks. So if they can't leave their encampment because everything they own will be stolen to go to the hospital, they also can't leave it to go to the park. And so what we do in response to that is go to the people. That's the catchphrase, I guess, of the Street Medicine Institute. And it looks like this. This is the OG USC Street Medicine team. We have a pickup truck. We go out in backpacks. The core of our teams, we've expanded a lot, but the core remains similar, where we have somebody who can prescribe, so a doctor, PA, or nurse practitioner, a nurse, and a community health worker who is somebody with lived experience in homelessness, who acts as our street guide and knows the streets better than anybody. We can provide a very high level of wound care on the street. We understand and do other things like point of care ultrasound. This is Dr. Olson, who's doing ultrasound on the back of a truck bed. But it's important to recognize that this is actually very common. This higher level of scope of practice is much more common than it used to be. When we started, street medicine was really this radical fringe movement that people would say we were irresponsible for trying to do this on the street. But it's evolved over the decades, where last year we published the California Street Medicine Landscape Analysis, which showed over 70% of street medicine programs were providing not just full service primary care, but also care for behavioral health on the street. We recognize that healthcare is more than an office visit, even if that office is under bridge. So 80% are dispensing medications. And we know that healthcare is more than an office visit and more than getting your medication. So 50% are also drawing labs on the street. And many of us are responding to other needs on the street, providing housing services, clothing services, insurance enrollment, and many, many other things. And so the question we come to now, as we shift our focus to hospitals, is why is care for people experiencing homelessness so difficult for hospitals? And the reasons are because even if you're perfect in the hospital, 100% perfect, and of course we're human, so we can't be 100% perfect, but even if we were, once they hit the chaos of the streets, all hell breaks loose. And we have the hospital that has very little control over it. There's a general lack of community supports. In general, hospitals rely on the community after somebody is discharged to help carry out those plans and help take over care. People that we care for in general, compared to house folks, don't have the same friend support system, same family support system. Brick and mortar PCPs are generally not accessible to people experiencing homelessness. We'll go over more of that in a bit. And shelters and other homeless service providers are generally not equipped to deal with people who are really sick. How many times have you sent patients to a shelter and they've been asked to leave because they can't take care of them? Or, some homeless service providers are incentivized to see volume. They want to get people off the street. Somebody who's very sick takes a lot more time, and they just might not feel comfortable with that. And so medical respite has been a great innovation with this. In California, we call it, now of course I'm drawing a blank, but recuperative care. Yes, thank you. Everywhere else it's respite. But it's by definition temporary. So most of the time they do end up hitting the streets. And then when all this happens, the hospitals get penalized for it. The people come back, and the people in the hospital are wondering what happened. And so what we've really witnessed with all this is that if there appears to be a lack of empathy for hospitals, that is really not what's happening. Sometimes a lack of empathy, what it is really is a lack of imagination for understanding what the reality of the street looks like and what people are facing. And sometimes it's self-protective, where they're on this futility merry-go-round. They think no matter what they're doing, it's just not helping. And so we're going to talk about what might help. And to understand what might help, first we have to understand what the experience, if we're going to call it an experience, of homelessness actually is. So I just wanted to share a few things. This is from some of our data at USC, where about 80% did not receive any outreach in the past 2 weeks. And this is a city that has, or a county that has well over 100 outreach teams out every day. The reason why we use 2 weeks is because we also know people either move or are moved almost 4 times a month. And 27% are eating 4 or less meals a week. We know that there's really high morbidity and mortality, so the relative risk ratio is almost 6. What this is the risk of morbidity and mortality. On average, the population is 1. This is the highest relative risk ratio just for experiencing homelessness. The second and third highest, by the way, are substance use disorders and mental health disorders. They're about 3, if that tells you anything about the severity of how homelessness impacts your health. And the mortality of the unsheltered is 3 times higher than sheltered and 10 times higher than the housed population, with 50% having trimorbidity, physical health, mental health, and substance use disorders, compared to 2% of the general population. And as much of the discharge planning involves following up with the PCP, right? That's who's supposed to take over care. We know that in this population, that just isn't happening. And we can't confuse insurance enrollment to access to actual care. And so we went on the streets of LA and we asked people, do they have insurance? Are they seeing a PCP? And while almost 75% had insurance, less than 10% were actually seeing a PCP. But what's our role in it? What's the role that we have played? Well, in general, there's a distrust in physicians. I don't believe this is unique to the physicians, but actually the system, because people feel that they've been treated poorly and discriminated against when they come see us. So this is not a general, they don't like systems or structures, but actually something that we've earned. And it's also not just a feeling, but there's actually evidence that there are significant disparities in the in-hospital care and mortality between homeless and non-homeless with cardiovascular conditions. So this is a discrimination that plays out in real life with real consequences. And so in a lot of ways, street medicine is an act of reconciliation that goes to the people and says that we're sorry for what they may have experienced. And so as we're looking for care in the inpatient setting, it's important to recognize it as a continuum, not just what's happening inside. There's the inpatient, there's care in the inpatient setting, there's the transition period, and then there's the outpatient support. In the inpatient setting, what we can pay attention to that will really help is first figuring out what's the denominator. Who is everybody that might need a little extra attention? And the first thing that the hospitals must answer, we all must answer really, is who do we feel that we're responsible for? Whose care are we responsible for? And when does that responsibility end? So if you're a hospital, is that care only for people who are currently admitted in the hospital? Is it only during the admission and the 30-day phase so that you don't get penalized financially? Or is it the whole community that you feel some responsibility for? And one way to express that responsibility is to screen for people experiencing homelessness so you know who needs that extra attention. Not systematically screening misses 50 to 75% of everybody experiencing homelessness. And when you screen is just as important as if you screen or not, because it impacts everything with their hospital stay. So the average length of stay is anywhere between 7 and 12 days. This is a time when they are a captive audience. You don't have to search for them in their encampment or under the bridge. There's so much you can do for them in that time. And I'll talk about our consult service later. But what we found is that we were getting consulted both in Allentown, Pennsylvania and Los Angeles around hospital day 4 and 5. So that meant it was being used as a discharge service, not a consult service, and we were losing those days. And I wanted to share this study with you because I think it really demonstrated the need to systematically screen. So this was actually done in Australia. And so they screened almost 3,000 people, 43% represented to the ED within 28 days. But this is the part to pay attention to. Who identified people experiencing homelessness? So the usual means were the clerical staff. They only identified 18 people, 18% of people. Then there was an alert team, which would be the equivalent of like an enhanced care manager or ED homeless navigator. They identified an additional 8%. And then the researchers screened everybody else, and they identified 74%. So in this hospital, they missed, by usual means, 74% of people experiencing homelessness. We did a similar study at Lehigh Valley and found similar numbers. The 17th Street one was the more urban environment. But I share this with you because in that study, we were able to validate a homeless screener for you to use. I know in the ED, you're asked to screen for lots of things. This is something that you're going to get positives for, and it will make a change in your treatment plan. So this is the one question that you can add that's been validated to screen for homelessness. And I also wanted to share some of our data that was published on who was coming in so folks can get an understanding of the complexity of this. So this is in LA General Hospital, the big county hospital. You'll see of the people coming in, over 90% were insured. The top admitting diagnosis was actually congestive heart failure, which I think would surprise some people, but it's the second highest cause of death. 85% reported substance use disorders, about 30% mental health disorders, 60% had three or more major medical illnesses. But one of the things that surprised us was of the length of time being unsheltered, the largest cohort had been unsheltered for 10 years or more. So this is a very complex population who's been on the street over 10 years. And so how can we expect hospitals to fix this in a few hours or a few days, discharging straight into some sort of home environment? And so as we switch our view to the transition setting, hospitals have really been given this responsibility to a safe discharge for housing, but the reality is that just that there lacks available options. Since 2017, I think it was enacted in 18, the coordinated entry system came about, which really limited people's ability to refer to shelters. Before, we used to just refer people to shelters and they could walk in. It's not that way anymore. You have to register them as homeless. You have to be part of the CES and they have to place you. So that means people can't self-refer to shelters. So this idea that was valid a few years ago, where hospitals could give you a list of resources and you could use those, is just not a reality anymore right out of the hospital. And following up with the PCP is just not a viable option. As we saw, less than 10% are engaged with the PCP unless that PCP is street medicine. And so just to demonstrate some of the realities of street movement and why this seems so difficult is because that it is very difficult. And so I wanted to tell you a story about a patient that's fairly long story. I'm going to abbreviate it just for the patient movement, about Takesha, who we care for with severe asthma, in and out of the hospital seemingly every month. And the hospital did whatever they could to place her. In the year after we started really taking care of her, she had 3 stays in interim housing, 2 stays in a medical respite, 1 stay in a nursing home, 9 inpatient hospital stays in 2 different hospitals, which meant 15 return trips to the street, 30 different location moves. 15 different providers and case managers touched her over that past year. But the one consistent thing was street medicine. It's not just about going to the people, but going where they go. And so there remains a need to create a reality-based discharge plan, which is part of what Corinne is going to talk about. When we started the program at USC, it is now built out with clinical arm, workforce development and education, which Corinne runs, where we train others how to do this work, a research arm and a policy and advocacy arm. But we started with this question of, I was the only full-time employee. It was Corinne and I. She was working in the PA program. There's 50,000 people experiencing unsheltered homelessness in LA. And so who's first? And we decided to use a hospital admission as a proxy for medical necessity, knowing that in Pennsylvania, the people we met in the hospital were much sicker than the people we met on the street. And so I wanted to share this concept with you. It's one of the most evidence-based things that we do as sort of a gold standard for hospital care. So it identifies those most in need of a very limited resource. And it does this by creating a consult service that functions just like any other consult service. So you would consult street medicine the same way you would consult cardiology, nephrology, any of those things. And it has 3 goals. The first goal is to work with the inpatient team to form a reality-based plan informed by knowledge of the street. And this is done through a tool that we developed with the acronym Housed Beds. That's what Corinne is going to go over next. The next goal is to, so you have the inpatient side, and that's done with the provider, a street medicine provider. The second goal is to avoid discharge to the street. And in the county hospital, we would get referrals after social work had tried to place them. 33% of the time, we were able to find a different placement other than going to the street. And the reason was because there is nothing scarier to a shelter than a referral from a hospital, coming straight from a hospital. And so we build those relationships. And if somebody is okay to go, they know that there's recourse, that we will follow them there. The other reason is we're able to vividly describe what their life is like on the street, and end up advocating for medical respite, for example. So, for example, somebody might have broken their leg. They were able to walk with a walker for 50 feet in the hospital, cleared for home with home PT, but they live in the riverbed, and to get food, part of their ADLs, they have to climb out of the riverbed, hop the fence, and walk a half a mile to get their food. They actually can't provide for their ADLs based on the reality of their lived environment. And so we would get them qualified for medical respite. And then finally, follow up to provide street-based care if they do end up hitting the street. We were able to successfully find people on the streets in LA somewhere on 73% of the time, compared to 27% lifetime engagement with PCP. That was within 1 week. Some other data from the consult service that I thought might interest you is the impact on emergency department visits. ED visits were down 80%. Some people hear this number and they're like, wow, that's really amazing. And it's not amazing. It's actually just logical. That if you imagine no PCPs, the only point of entry into the healthcare system is through the ED, which is how they're usually forced to access care, you could see how ED visits would skyrocket. And so we were not doing anything special, just providing an alternative to brick and mortar care that is accessible and acceptable to their lived reality. We looked at 30-day readmission rates. So on the left is what I like to think of as life without street medicine. So there was one published study with a 50% readmission rate. At the LAC USC, the county hospital, it was about 30%. It was the same in Pennsylvania too. And then on the right, life with street medicine consult service. In Pennsylvania, we got it down to 11% and under 10% in Los Angeles. And when we started, they said, don't you dare prevent readmissions by making them stay longer. And so we also paid attention to length of stay. As you know, if you work in a hospital, length of stay is usually measured in hours, not days. But this decreased by multiple days. We didn't, just so folks know, we didn't do the consult service with the goal of providing these metrics or getting these metrics. The goal was to provide the best care possible. And the metrics were simply a side effect of that. And so now is the call to action. So what can you do today within your hospitals or from the outside working with the hospitals? So hospitals can screen for homelessness. As we know, if you feel a responsibility to care for your community or at least the people coming in, you need to know who needs this care. You can operationalize house beds. Corinne will talk about that. You can connect with homeless service providers who are doing this work and find out who might be able to help you. And a lot of organizations have these ED navigators. I mention this because this is something that you can do right now, but just a caveat that the results will be limited simply because the ED navigator, it's hard to solve all those problems that we talked about within a few hours or within a few days in the hospital. And the service providers just aren't equipped to take those referrals. You could send them a referral and then they have to look for somebody that they don't know what they look like somewhere on the streets of LA. The chances of them finding them is approaching zero. So these are things you should do, you can do right away, but understand the results will be limited. You can connect with street medicine providers in your area. These are the teams that are going to be most equipped to handle people experiencing homelessness who also have complex comorbidities, medical comorbidities. Read the materials that they'll present later in the webinar. But what's the best thing you can do? The number one thing you can do is to create a street medicine inpatient consult service. This is the best intervention that we know. Hospitals are doing this either by creating their own services or subcontracting with a street medicine provider who can come into the hospital and then follow them out on the street. This is the most evidence-based intervention that we know. And so with that, I will hand it over to Corinne.
Go. I couldn't find my unmute button. So, so I'm going to talk for a couple minutes here on this house beds tool. And house beds is an acronym, just like many that we learn in our respective fields of medicine. I think one of the things to sort of conceptualize is that checklists are really, really common in, the world of folks experiencing homelessness. And a lot of those checklists are requirements for them to potentially get different things that they need, like housing or income. And a lot of times our folks feel that they've given lots and lots of information with not a whole lot in return. And so if you want to use something like house beds, which is going to ask them a lot of questions about kind of how they do life, my advice to you is to get some style points, to have kind of a coffee and a chat approach to these sorts of questions. And this tool is really designed with a interdisciplinary team in mind. Anybody with any background can ask these sorts of questions. And the information that's gathered can be used by a range of team members. If somebody doesn't have access to a bathroom, that may impact the type or dose of a diuretic that I give. If they don't have access to a bathroom, it might impact something differently for one of our social work or therapy team members. So this is designed for anybody to use, because the goal, as Brett said, was really to expand your imagination. It's really hard to come up with a collaborative plan when we can't imagine the situations in which people find themselves to meet their basic needs. And so in many ways, and Brett is frequently saying this is really like a listening tool. How do you elicit some of this information that's really going to inform some of the decisions you make together? And so we start with H for homeless history. And typically when we're asking these sorts of questions, even in the hospital side of the house, we're asking, where did you sleep the night before you were in the hospital? And how long have you been in that spot? Now, one of the things we're listening for is duration of homelessness. So we think about homelessness in terms of chronically homeless, which I have defined here in this red box, or transitionally homeless. And one of the things that comes to mind is we know that the longer folks have been homeless, the more they've been exposed to all sorts of things, right? Toxic stress, but also environmental things and violence and whatnot. And so, so we're interested in how long folks have been homeless. We're also listening for other important designations as it relates to ways they may be able to end their homelessness. And sometimes the hospital path, or the pathway out of the hospital, is the first steps in somebody's homelessness coming to an end. So other things that are important to be listening for is this age range of transitional age youth for 18 to 24-year-olds, where there are different kind of streams of funding to support this particular age group, veteran status and prior foster care involvement, particularly if they're under the age of 26. So again, there's just sort of these different pieces of information that may open up other possibilities. Personally, one of the things I find really insightful, whether I was seeing patients, inside the hospital or outside, was what makes their spot a good spot, because this gives you a lot of context to their life, why there are really good reasons people have chosen the spot that they're in. And so that can really help you kind of picture what kind of supports they may have around, or what kind of areas they're in, and they may not know what those supports are. We often have folks, for example, if they're released from the carceral system, you're not always incarcerated in your hometown. And so people often find themselves in a place that they know nothing about. And so that can be another way to sort of customize what you recommend. Chronicity of homelessness really equals complexity, right? Complexity in their health, a representation of the degradation of social structures, safety net kind of mechanisms that people have in place. And so we also see some really interesting data emerging around the idea of premature aging from our colleagues at the Benioff Center at UCSF. This idea that 40 is the new 60 and 50 is the new 70 if you're somebody who's experiencing homelessness. And this impacts our differential, right? I can't say that in all of my years, working on inpatient or in a clinic, that if a 40-year-old was coming in with shortness of breath, that I would be thinking, gee, I wonder if their ejection fraction is 11% or 14%. But we do know that in this population, sometimes these things we're expecting in much older or people with more advanced age are happening at younger ages. So it really makes you think about your differential. We also need to recognize that survivors are in survivor mode when they get admitted to the inpatient facilities. And there's two main ways I just want to frame the behaviors that you often see. Hyper-independence, sort of this survival tactic of if I can't rely on anybody else, I know that I can rely on myself because I have, by virtue of surviving being homeless. This hyper-independence is also a trauma response. And so collaboration is really, really important in sort of honoring the fact that folks have survived up until this point, given all of the things that have been challenges in their life. And so sometimes conflict can happen in the hospital when we see that hyper-independence and view it as sort of a challenge. The other thing that happens is sleeping soundly in a safe place. Folks are not necessarily malingering when they are solidly asleep in the ER or in the hospital. If you imagine that every time you shut your eyes to go to sleep anywhere, that someone statistically is likely to hurt you while you're sleeping, you can imagine that sleeping in a hospital bed where you know that people will protect you may give you the rest that your exhausted soul really needs. O is for outreach, and we really want the hospital system to be part of sort of this triangulation, right, of outreach services and where folks leave to go to for social services and where they may be accessing care. And so we're interested in who comes, right, to see this patient and what are they offering and when, did you last see them and how is that relationship? So how this plays into some of the things we think about when folks are admitted is like, who else do you call when you need context for someone's life? I worked in trauma for a really long time, and I would call family members and call, anybody listed in the chart to try to understand the context of this person's life and what is the baseline we're trying to return them back to in the case of, many head injuries and things like that. So a lot of times these outreach teams are the folks that know your patient the best and what their role in the transition out of the hospital might be. There have been many, many times that we have been called, myself, Brett, our team members, Joseph, when our patients are thinking about signing out AMA. And they're in the middle of a workup and everyone is very worried about them. And so sometimes these outreach teams, even if they can't physically come in and visit this person in the hospital, are really good allies, right? For just some of that sticking power of, being able to talk to folks, maybe convince them to stay or figure out what the barriers are. And then knowing who the patient's strengths, what their strengths and their assets are. Because again, we're trying to play in all cases to the strengths of people to understand what's important to them as we're creating a discharge plan. U is for utilization. And in contrast to outreach, where we view that as who comes to see the patient and who might know them in that sort of home context, utilization is where does the patient go to? And so, of course, you're probably already asking, like, who is your PCP and when did you last see them and ER visits. But there are other things from the inpatient side we can do to support our patients. So, for example, there's an increase in criminalizing homelessness across our country. And so patients often have some legal challenges. I think one of the most impactful things we can do on the inpatient side is and knowing why you're asking this question so it doesn't freak out your patient, but if they're on parole and they have a parole officer, you don't want them to be in violation of the parole by virtue of the fact that they were sick. And so we will connect with those parole officers, of course, with permission from the patient to let them know that the patient is in fact, sick and being cared for. The other piece is, where are the social services that they're able to go and see? Can they leave their encampment? And for what reason? I mean, this does tell you about folks' priorities, right? If every time I left my house to go grocery shopping or to go to a doctor's appointment or to take a shower, there was a chance that my place would be burned to the ground, that it would be ransacked, or, you know, a range of other things happen to my existing property, I'd have to be pretty motivated, right, in order to do those things. And so we're interested in who else knows this person. Who are the community lifeguards? Again, because we're thinking about that sticking power, the context. We've had some of our best community advocates are like the folks who run the laundromat, who know our patients and things like that. But it does tell you what people will reliably seek out. And this may enter in to your care plan. There's lots and lots of folks who are discharged with wounds, and we think about showers, we think about food access. I think about drop-in centers or even public libraries. You know, I wish I had the authority to deputize librarians as public health warriors, because they really are serving so many roles in our communities. But these are just simply places that people can get out of the elements. Just talking to a colleague in Michigan, and it's dropped 20, 30 degrees, right? It's cold. And places that we know people will reliably call 911 to support our patients. We also want to think about income. So, you know, it's very frequent. Brett and I were talking about this when we were putting together the presentation, that we're doing our medical history and we're really thorough and we think we've got it. And then we get to salary and income, and it turns out that our patient receives SSD. And we find out by asking, well, why did you end up getting that? That they actually do have a lot of things going on, in particular mental health conditions that may have been the reason they were able to be successful at getting SSD. General relief money, sex work, panhandling, you know, our folks are frequently employed. And of course, if they have insurance. I think the take-home message here is that surviving takes a lot of energy and time and distance. And so if you learn that your patient is panhandling or recycling, asking some details about that, not so that you can come visit them on a Friday afternoon, although you're welcome to, but it does define functional community distance in a little bit of a different mindset. And so this picture is actually an accompaniment to the one that Brett showed, because it's such a great example of this guy who really had some vision and ambulation issues, who needed to walk out of the woods and cross this makeshift bridge in order to get basically anything that would fit under the umbrella of basic needs. Also remember that work notes still apply. I actually just wrote a work note for a patient of mine who was admitted to the hospital for 8 days, and he unloads trucks and kind of, you know, works for different folks. And he was worried they weren't going to hire him back because he had gotten really, really sick and was trying to keep that job to save some money for basically going back to his family in Northern California. So his work note allowed him to maintain that just like anybody else. So our next 3 letters, I think, are incredibly helpful to think about on the inpatient side: eat, drink, and bathroom. So Brett had mentioned some of the data around the frequency of meals. We specifically ask about meals and not snacks, because we cannot survive on granola bars and fruit snacks alone. And when we're thinking about overall health, wellness, recovery, recuperation, wound care, meals are really where are more nutritious than our snacks. We want to know where they're getting their food, and if they have safety concerns. And really the biggest decision tree here, or how this impacts us the most directly, I think, in the medical in the inpatient side, is thinking about medications, right? Folks that are being discharged on NSAIDs or steroids, knowing that the majority of the time they're going to take those medications on an empty stomach. Are the medications needed for absorption? We treat a tremendous amount of hepatitis C on the street. And so I think a lot about which hepatitis C treatment, of which we're so fortunate now, what a time to be alive, that we've got a lot of options, but not, you know, we have to think about if people are going to be able to have food at least once a day in order to take their medication. We think a ton about managing diabetes, and this is kind of a whole discussion in and of itself, but really thinking about, often as we do in clinic medicine, who are we really aiming to max out our oral medications versus who's a good candidate for insulin. Insulin management is possible on the street, but it depends on food patterns and all sorts of things. We think about food in terms of wound healing. And one of the biggest challenges we have is ordering things, or patients have trouble getting once they've left the hospital, are things like Ensure and Boost. They're obviously very expensive to buy over the counter. And so my shameless plea to order those things if our patients qualify for them, so they can walk out of the hospital with those. When we think about access to clean water, the source of their water, how much water a day, and we ask, about concern for water safety as well. Things that are really important to consider is that a lack of food and water safety is really, really common. And so we see folks with infectious diarrhea much more often as a result of kind of the feast or famine that our folks are typically facing. So thinking about that in terms of education, thinking about, in general, everyone is relatively dehydrated if they're living without a home. And so who really needs fluid restriction? We've seen it go south a whole lot of different ways. We have patients that come out of the hospital, they're put on a fluid restriction, and their water goes from, consistent or controlled access in a hospital setting to having almost no reliable access to water in the outpatient and sort of outside world. And thinking about diuretics, right? Diuretics in the face of inconsistent water and bathroom access, walking many, many steps a day, kind of the insensible losses like sweating, right? Or folks wear multiple layers of clothing due to a lack of storage for those clothes. And so all of this sort of contributes to the challenges of diuretics, of which many people need them. But the question becomes, what is the actual appropriate dose for somebody on furosemide when they're living without shelter? And so, traditionally, folks that come out of the hospital needing these medications need a much lower dose to be safe. B is for bathroom. Everybody wants 24-hour access. If I asked for a Mentimeter, I'm sure it would be 100% yes. Okay, but there's tons and tons of barriers to accessing a toilet 24/7. I think this and sort of the last slide is really best described with our patient Denise, who died a couple of years ago. And she had hepatic encephalopathy. She would get admitted to the hospital, and she would get all of the appropriate, standard of care, appropriately diuresed, and her encephalopathy would clear, and she would be put on lactulose and discharged to the street. No one knew for many years, looking at her charts, that she was experiencing homelessness during these hospitalizations. And she ended up in this cycle where she would want to take those medications. She recognized that they were really important and helped her feel better. But the problem was she had access to a bathroom only when it was light outside, because the closest bathroom was a park that locked the door, locked the restroom doors at night. And it was quite a distance. And she had some arthritis in her knees. And so she ended up in this really precarious situation where she would take the medications, but inevitably not make it to the bathroom in time. And there were real consequences for, not having additional clothing that you could change into if you've had incontinence or things like that. And so then she would stop taking the medicine and go back into the hospital. And she would often report such shame that she felt when she went back into the hospital, because people would comment that she was just not adherent to her medications. When the reality was, there was something else she could be put on that wouldn't cause diarrhea, that she wasn't offered until very late in her disease course, but also that there was just a lot of complexity to what she was dealing with outside. The last couple of letters, from an inpatient perspective, knowing a general area where somebody's encampment is located is very helpful, especially if you're thinking about resources and things like that. The type of shelter gives you an idea of their environmental exposure. Is this somebody who is sleeping with just a blanket over top of them, or nothing over top of them, or they're in a tent or some sort of makeshift structure? Sleeping position may seem a little bit odd, but wait, I can explain. Lots and lots of our folks sleep sitting up for a range of reasons. Number one, personal safety, especially our women who are riding public transportation often all night for protection. people who are sitting on park benches, and the benches have those little armrests every 3 feet, so you can't lay down. And so what happens is they end up with these really large swollen legs and subsequent venous stasis ulcers that can be really tricky to heal because of that upright sleeping position. And then, safety concerns, both safety concerns and who in your encampment can support you. Then finally, daily routine. Again, this is about an imagination. I think there's a misconception that folks who are experiencing homelessness just hang out in their encampment all day, every day, and don't have any sort of routine. And that in the last 17 years, that has not been our experience. And so understanding what that is can be really critical. And then finally, substance use. And I'll be the first to admit there's nothing earth-shattering on here. We included it as our final S in house beds because we just know that we don't do a great job of documenting this in the chart and really understanding the journey that folks may be on if they're using substances. It's also a reminder that people who are using opioids, for example, still have legitimate pain, right? And they still need that adequate pain control and really considering, is this the day? We see lots of our patients who end up with no pain medications being given or very little because of their opioid use disorder. And this usually precipitates withdrawal and a lot of conflict in the hospital rather than, managing pain appropriately as we would do our other patients. And so that is the quick run through House Beds Hospital Edition, but we've got our emails here, and I'll turn it over to Katie and Caitlin to talk about their discharge planning tool.
Great. Thank you so much, Corinne and Brett, and Katie's bringing up our slides here. There's been a few great questions in the Q&A as well. So if folks are interested, Brett has been answering them if you're interested in seeing what other folks are listening into. So Katie and I are now going to share about the resource that has been launched as of today. We're very pleased about it. The Creating Care and Discharge Plans for People Experiencing Homelessness or Hospitalized Toolkit. We don't have a fun acronym. We should have thought of that as we were creating this. So we can go to the next slide. But ideally, the hope of this toolkit will really be to be able to kind of give some tangible action plans that relate after you've done this house bed tool and identified these needs. What does that look like in your discharge plan based on who you are and your role in the system? So in terms of developing this toolkit, we are really pleased to partner with CommonSpirit and our members of our community to do some listening sessions across the board. So we spoke with folks who are working in the hospital across a variety of settings and provider types, folks in the community working in shelter, medical respite, community health center spaces, really being able to get a grasp of what were the barriers and also what are the innovative ideas that folks are doing to help resolve some of these issues. We additionally did a review of the literature and existing resources and ways that communities have attempted to approach this issue. To developing this toolkit, we then drafted resources that were reviewed by folks working in these roles in the field, again, to make sure that they were tangible, applicable, something that could be utilized day to day. We reviewed that feedback, integrated the feedback. If some of you are on this call, thank you for doing that for us. And that brings us to today to the webinar where we're learning broadly about our approach to care and then being able to think about this toolkit. And then hopefully, Katie, if you want to click one more time, will empower all of you to take this information learned today. You're gonna have to click like 5 times. This is the drawbacks of animation. Hopefully what you all will take with you today is feeling empowered and having the heart to be able to support our folks who are unhoused when they are within whatever setting it is that you are in together today. Next slide. There we go. So what is the need for this toolkit, right? We know sort of on the ground that there is a significant moral injury for providers who lack solutions such as housing. I can't think of one of the more challenging jobs than a hospital social worker who is the discharge planner, who has folks who have a need that cannot be resolved, right, with what is available in the community. And that is really challenging for everybody across the board. We know that there are communities where folks are experiencing hospital dumping in which there is no discharge plan set for them, and there are dangerous things happening for our folks, especially more dangerous as being outside is now being criminalized, right? And this is really resulting for folks in issues around their medical care, quick returns and ED readmission, and sort of perpetuating the cycle that is not helpful for anyone. We know from clinical practice that often what we learn in school and, even in our direct experiences in the field don't account for unstable housing or lack of resources. I'm an occupational therapist, and I can't think of one clinical case example that I did in school where there wasn't a caregiver or somebody wasn't unhoused, right? That's not something that is part of typical learning. And so there is, again, that imagination and creativity required to take what we know as best practice and make it work for folks who lack some of these resources. We also know that folks who are unhoused experience significantly higher levels of bias and stigma, and this can be enhanced if they are any part of any other groups that are frequently marginalized or stigmatized, and that affects their ability to engage in care, willingness to engage in care, and seek resources when they need to. And we just have to recognize, I think there's a larger elephant in the room here, that we don't necessarily want to have these toolkits and resources, right? But because we exist in a space where there's a consistent lack of investment and affordable and accessible housing, we need approaches to improve care for people who are unhoused, whatever medical setting that they are in. Ideally, we won't need these resources because people will have housing, but because of this is where we are, these are the type of things that we need. And so hopefully this toolkit will help fill some of those gaps. So in terms of applying the toolkit, it's structured in a way that hopefully will be really useful, whether or not you are individual or part of someone who can make change in a larger system. If you are an individual provider, you will be able to use this toolkit by finding your checklist that applies to you in your role in the system and be able to use it directly to engage with your patients. Hopefully, what this means, though, is that your entire team might adopt this approach, that everybody will be thinking about housing status and having that incorporate into their discharge plan so that the rehab professionals, the social workers, the prescribing providers are all centralizing this as part of their plan. Even more ideally, we're hoping that there's going to be some systems level change, that perhaps your hospital system or your healthcare system that you are participating in wants to adopt this approach and change their approach to care for people who are unhoused, so that you're not the only one sort of fighting the good fight, so to speak. And then ideally, again, we hope that this toolkit becomes part of a even much larger community effort to address the needs of people experiencing homelessness, and can be part of that systems integration and communication between hospital and outpatient medical, street medicine, shelter settings, all those places where people engage. And so what does the toolkit include? Now we're going to kind of dive into the nitty-gritty now that we know the why around of why it exists. The first thing that it includes is a findings document, which is really, if you want to do a deep dive into the listening sessions that we had with providers on the ground to learn about what challenges people were experiencing and some of the innovative approaches that they have taken on. I will say, hopefully, if you scan the QR code, it will take you to the toolkit. You may have to log in to see it, but it should take you there. We also have introductory videos. And so if you are new around learning approaches to supporting people experiencing homelessness, we have some introductory videos that either you or can recommend to other folks to be able to take to really understand what is contributing to homelessness in the United States right now. What are approaches to care that we need to take? What do discharge environments look like? If you're unfamiliar with what shelters really are or what living in an encampment looks like, this will help you be able to set that framework, which will then help you be able to develop your care plan. We also have discipline-specific checklists. So there's an individualized checklist for prescribing providers, for nursing staff, social workers, occupational therapists, and physical therapists. So whatever role that you are, there's a checklist for you, and there's an introductory video that helps you understand kind of how to use and apply that checklist should it be needed. And then finally, we've included some additional resources and links in case you would like to do a deeper dive into any of the concepts we've presented. There's more information out there that you can take and learn more about. So I'm going to turn it over to Katie, who's going to kind of give a snapshot of the toolkit and what you might find once you go in there.
Thank you, Caitlin. Yes, we are so excited to launch this and make this available to you. It is something that is the product of so much input and work based on hospital staff and community-based staff, as Caitlin was discussing. So we hope it is something that is immediately useful to you all and your teams. So this is a little bit of what it looks like. We want you to actually see, if you are new to our learning management system, our LMS system, We welcome you to explore and look around at the other courses, but let's start with the one that has this toolkit. And so this is your landing page, is what you will see. And it is designed so that, as Caitlin said, you can use individual sections of it. You do not need to take the whole course in order to be able to access and download the different portions of it. As we've talked about, there are findings documents, there are checklists that will be useful for you. Those, we hope, each is printable on a standard 8.5 by 11 sheet. We tried to keep them, I believe the nursing one's just a little bit over, but everything else is just a single sheet of paper. The videos may be useful to you all. They're both introductions to the individual sessions, as well as really great introductory videos for serving individuals experiencing homelessness. For those of you who might be hiring new staff or have staff who this is a new population in which you are working with, these can be really helpful foundational videos that go into depth a little bit about the discharge locations and some of the unique needs of individuals experiencing homelessness. And then those resources are for those of you that are interested in taking a deeper dive. So when you navigate this, the first you're going to see when you enter into our LMS system, you're going to see this toolkit, the Creating Care and Discharge Plans for People Experiencing Homelessness Who Are Hospitalized toolkit. I have yet to be able to do it in a single breath for the title, but it is, you will be able to delve right into it. And then to navigate the components of it, you will see on the left-hand side this navigation bar, and you can click on individual sections. You do not need to go through it all step by step, starting at the top. There's a little bit of a scroll. So if you do not see your discipline, please scroll, because as Caitlin mentioned, there is a toolkit for most members of a hospital care team. And then right at the top, and the reason we wanted to draw your attention to this is you can download all of these components to it. It is so important to us that you are able to take the pieces that are useful to you and adapt them to your settings. We want you to know that the expectation is not that you are taking the entire toolkit in its entirety or even each checklist in its entirety. You can hopefully personalize this for your own settings, and that can adapt to the community resources that you have, to the resources within your hospital. For those of you that are fortunate enough to have medical respite or recuperative care, there are parts of the checklist that will be applicable to you. These are also toolkits. These checklists can be used to leverage for resources needed. So as you're looking through these checklists, if you say, this is really a gap we have in our community, who in your community can be a part of creating those resources or advocating for those resources. One of the things we know in direct service is that advocating for things at the systems level is what can help prevent burnout for those of us working at the front line. So these pieces also might highlight gaps in your community, or it might be a scavenger hunt to go find the community providers that do offer those services. So if you look at this and say, I actually don't know if our community has this type of resource, it can serve as that roadmap for finding who some of those community partners might be. Early on, we did that Likert scale assessment of how you feel that discharge process, or how that smooth that transition is for the people you serve. How is it that you can help smooth that out a little bit? And hopefully these checklists will make that process a little bit smoother for you all, because you will see where the gaps are, where your needs are, or maybe develop workflows for it. So we welcome your feedback, and please take this as an opportunity to look at these and let us know what more needs to be a part of it, where you see changes. And we hope that it is something that you will be able to apply as you leave this webinar today. So before I pull this down, just a friendly reminder, we've been getting great questions in the Q&A. Now is your chance. I've got one more slide that I'm going to show, I believe, before we pull this down and have an opportunity to hear from Corinne and Brett again to answer any questions. Caitlin and I are also here to answer questions, but using that Q&A chat feature, please. I think most have found it, but if you have any questions. And as promised, we are putting up this CEU slide again. There also was what they call a lobby, which what Zoom calls a lobby. You probably should still be able to see behind our video screen. You can see the main Zoom screen that has these downloadable resources that will tell you how to get the CEUs for your respective discipline. We will also make sure to drop in the chat the link to the landing page for this event. Zoom, we will send out follow-up emails, but also if you have this, if you bookmark this landing page, it will take you to the recording of this session, to resources that we link from our perspective. It will have the house bed toolkit link on it. It will have our toolkit linked right on it, how to get to our LMS. So hopefully that is a bookmark that will be useful to you. So with that, I am going to pull this down, and I think Caitlin might have the first question teed up, ready to go.
Yeah, there's a couple of great questions in the chat, and I know that they were typed answers, but I think they're really important ones that we'll highlight for everybody here who may not have been following that. And I think one big piece of the conversation and the S of the housed beds around substance use. And so really wanting to highlight, the struggle around discharging patients with substance use disorders and what resources there might be around that, or how that can be integrated into the approach.
Yeah, so I mean, if somebody is, I'm assuming this is somebody leaving the hospital who's looking for treatment. If they're not looking for treatment, then it's hard to get them treatment. If they are obviously inpatient facilities for them to go to, people try to do that, but the reality is most of the time that's almost impossible from the hospital setting. And so you have to figure out who's going to, like right now, for example, and the example I gave in the chat is MAT, and a lot of hospitals are setting up these bridge programs, which are brilliant, where they can start MAT right in the hospital. The challenge with the bridge program is who's going to write the second prescription after they leave the hospital, and that's where a lot of this is falling off. And so the key is to find who is going to write number two. That's where your friendly neighborhood street medicine provider comes in. They will, ideally they can come to the hospital and meet the person, which is part of what makes the consult service so valuable, is that it's almost impossible for them to receive a referral and find somebody on the street when they don't know what they look like, where to look reliably, and the person doesn't know what they look like, which is just as important, because they'll come out, I'm looking for them. I'm like, hey, is Joe there? Nobody knows. Even Joe doesn't know who Joe is, especially with me, because I look like a cop. And so it's important that they saw me in the hospital, and to make that bridge. If there's not a street medicine program, and I saw one of the questions was, how do we know if there's a street medicine program? If there's not a street medicine program, I know some hospitals are offering people to come back to the hospital and to a bridge clinic. That can be very hard. It's the same barriers as coming to a brick and mortar clinic. But it's definitely something to think about carefully when you're setting up these bridge programs.
I think, Caitlin, just one other thing I would add, one of our challenges is when they have a medical need and then they have an underlying substance need as well. And I think one of the things we're trying to do from a healthcare system is really work with our community-based organizations to talk about what level of services can be seen in different settings, and if there's opportunities to address substance use or substance needs within the context, but recognizing that that might require higher level of care, and really kind of working together in partnership with our community-based organizations. That might be recuperative care, that might be, shelters, to really understand what their level of acuity that they're comfortable with, and where we might explore some pilots. I think one of the things that are being brought up here is, how do we start this? And one of the things from the health system side is what we're learning is it's okay to start small. It's okay to have really small pilots, especially in rural communities, to talk about, how do we serve 2 or 3 people to build this understanding in this continuum? Because I think sometimes it can feel overwhelming and not knowing where to start. So I think pilots where we can address some of these unique needs, and also, starting small as a space to explore within the substance use, but also overall within building the larger continuum of care.
Yeah,
Yeah.
and I will point to in the prescribing provider toolkit, there is a section around behavioral health and substance use needs. And, minimally, I think it is in part education for the person. There's an increased risk of overdose after hospitalization for folks, especially if they haven't been getting prescribed medications that meet what their substance use was prior to hospitalization. So minimally, from that harm reduction perspective of educating folks on risk of overdose and making sure people are walking out the door with naloxone or other resources related to that, can be also a place to start, and especially accessible for folks who maybe are not entering treatment or not, treatment is not the right thing for them at this time. So just want to highlight, there's sort of some different levels and layers of things that we can do depending on where the person is.
Yeah, and I think just making sure that looking at for those of us in the community side, thinking of how are our services low barrier in terms of being able to access that next dose, or that second prescription, as Brett said, like what are we doing to make it available on how can we analyze our internal policies and procedures to modify to better meet the needs of those clients? And just thinking, because I think the worlds of our street medicine providers across the country, for a couple of the questions that have come in is, there are a lot of, street medicine can come from a lot of different sides. Hospitals can be the ones leading the ways and having their staff actually have rotations that are out as street medicine providers. And so if your community doesn't have it, don't say that, oh, we don't have it, so we can't have it, is thinking of who is going to be the one to start this movement. And that might be a single session out in the community in a 40-hour work week or 80-hour work week, as hospital staff are so busy. What can we do to just crack that door a little bit, because it demonstrates, as Ashley said, that the value of a pilot shows both the efficacy and the need simultaneously, which can speak to leveraging a greater backing for programs like that. And so, and knowing that we need to, on the other side, in the community-based side, how are we modeling our practices to receive somebody who is being discharged to be low enough barrier that those great guardrails that have been in place, particularly in the substance use space, if somebody was open to MAT treatment, or how are we making sure that we are receiving them in a way that that can still meet their needs because they've expressed an interest in this?
I just wanted to add a message to the street medicine folks out there and the community folks. Hospitals don't just refer to homeless service providers. They refer to many, many, many providers. And they're doing their best to keep track of everybody. And so the easier you can make it for them to find you, the more likely that they will find you. And so if you have a very hard referral process with a form that needs to be submitted to that they can't find, to a number that they can't find, and an inclusion criteria that they can't find, you're probably not going to get the referral. And so one of the things that we did right away is it's just a cell phone number that somebody carries all the time. And so to place the referral, they just need to call that cell phone number. And somebody will answer that can take the referral.
Yeah, I think, Brett, just to carry on that, the relationships are the foundational piece of this work. And I know that takes time and energy, but when you start building the relationships and the trust with the different organizations between health systems and whatever service providers are out there, it creates an opportunity to really approach this together, to identify, your shared objectives with serving the same population. I think one of the things that we try to enhance within the health system side is making sure our service providers and our discharge planners can actually tour the sites that they're referring to, because it makes a huge difference. We know staff that has gone out with street medicine on a site tour with you guys. In most of our regions across the different states, our number one thing is get out to the partners and see the site, see the space, and then you start to understand why certain individuals may be appropriate for those placements and why others may not be, and recognizing there's not going to be one approach for every single individual experiencing homelessness. And I think understanding that each person brings in their own story and their own needs is really a unique approach that we have to be mindful of with every discharge.
So looking at the time, I think we have one last question that we would love for you all just to share some insights in, which will hopefully summarize a few of the different questions we have in the chat. I think one of the biggest challenges always in homeless services is how do we fund this and how do we make sure that these programs that we're setting up are sustainable? So I'm hoping that both Brett and Corinne and Ashley, you all might be able to share little insights on how do we fund pilots and how do we fund these initiatives ongoing?
Great
You
question.
want to go first or?
No, go ahead, Ashley. You go. Go ahead.
I think from a health system perspective, again, really looking at it from a collaborative standpoint versus a funder and grantee relationship helps change the dynamic. We are definitely invested in this space. I think it's also the understanding what are, being explored through Medicaid. Medicaid right now is making some major changes to address homelessness in a variety of different settings, and that varies state by state. But really working in partnership with your local hospitals, with the service providers and with the payers to talk about, how do we collectively approach this work? Obviously, not everyone is going to be covered through some kind of payer, and especially in non-expansion states, that changes. But I think really understanding how you're working together and building a program and a response that's in a collaborative manner helps not put the financial piece up front, but recognizing there is going to be a financial component. How do we build that into understanding how we sustain this? What's long-term sustainability? I think one thing from our health system that we're trying to make sure we understand internally is that it does cost money. It's not a free service. And we often talk about ROI, and I think we're very cautious to talk about what, the impact is on length of stay, what's the impact on getting them connected to more community-based services and part of the continuum, and not so much focus within the 6 months of investment. You're going to have this ROI because it takes time. And we know oftentimes, as Corinne and Brett, alluded to, people do come back in the hospital. And so it's not a, fix with once they're connected to services, we don't see them again, or there's an immediate ROI. So I think it's understanding what those shared objectives and impacts are and building the relationship on that. But there's going to be a financial ask. It's just, if that comes up first versus the relationship, it puts everyone kind of at a different dynamic than how do we approach this together?
And I'm going to give Brett a chance to answer. I'm just going to launch our poll as we are wrapping up our last few minutes. Please, for those who are still on the call, thank you for being with us. And if you could take a few moments on our survey, that would be wonderful. Brett?
Oh, yeah, no, that was an excellent answer. I guess the only other thing I would add is that one of the other things that we co-created was a street medicine financing toolkit, which will help you at least figure out what you need to finance an outpatient street medicine program. Maybe we can send that, Katie. And then I also saw some mentions about Medicaid funding street medicine. There are a lot of people here from California. Options that we have in California are not options in most other states or any other state that I'm aware of. So just keep that in mind if you're from California. But none of this really pays for the time to go in and do the consult. The place of service code is an outpatient code. The inpatient consult service would require a different taxonomy code, as far as I understand. And so that's something for hospitals and street medicine providers to work out if they're asking folks to come into the hospital.
Thank you, Brett. Oh, go ahead, Corinne.
All right. I just have one quick thing to add. I think identifying partners within the hospital system, I think it can feel really overwhelming to be like, well, who would I even send an email to or request, help from? And I think really looking at your hospital structures, a lot of times folks who are related to the transitions of care or discharge planning, there are folks in hospitals that are really specifically focused on that. We've had a lot of success talking with those folks. I joke, but I'm not joking. MD MPHs tend to be really good champions of this because it's combining this public health and medical health view. And so there are some tips and tricks related to that that I think can be really helpful.
Yeah, I did answer the question also, if you have a local community health leader, because they're often ones, connecting the community and the hospital together, discharge planners. I think current transitions of care is a huge opportunity. It may take a few times to reach out, but We haven't found one that there's not interest in partner. It's just kind of figuring out what that looks like. But I think we are at time. We had 90 minutes of hopefully extremely valuable information being shared. I think this webinar highlights the importance of collaboration. You have street medicine providers who were previously acute providers in the hospital. You have our colleagues at the National Healthcare for the Homeless Council who are really leading so much of these resources for serving our individuals experiencing homelessness, and from a health system with CommonSpirit Health, where this is ingrained in who we are as a mission and as an organization. So thank you so much. You will get copies of the webinar. You will get the recording. All the CEUs should be included there, but all our contacts information is included as well if you have any follow-up questions. And we're hopeful that this might be one of many future trainings. So let us know what you think. Please take the evaluation, and we look forward to connecting soon. Thank you so much, everyone, and hope you have a wonderful day.